Stimulating and provocative comments. I want to, I'm going to break a little with tradition. I'm going to ask the first question and let everybody now think about what they want the second and third and fourth question to do. And I want to go to Diana. Because, you know, there has been a little bit of a mood of self-congratulation around here that the campaign has gone forward. We had lots of reports about all the activities in the last 5 years, and we have a number of markers that we can point to that we think makes it look as if the world is better for nurses and ultimately for patients in healthcare. But Diana, you reminded us that the world isn't perfect, and in fact there's a way to go here, and maybe reinforce the point that I made at the beginning that nurses alone can't control their destiny or the healthcare system, that other things are going to have to change too in organizations and in the other health professions. So you said you had some recommendations for us, and I want to give you a few extra minutes to give your recommendations, and then we'll open it up for questions.
Thank you. And I had a whole other opening to my comments about being a nurse for 45 years, and this being the most hope, the Future of Nursing Report, restoring my hope that I'll go to my grave and things will change. So one of the recommendations that I have is that I've been involved with a group that has been put together with funding from the ABIM Foundation, American Hospital Association Foundation, Commonwealth Foundation, and others, to develop standards of professionalism for healthcare organizations. This was after the ABIM Foundation had developed standards for physicians, standards of professionalism for physicians, and they went back to the physicians and said, how are you doing? Are you living up to the standards? And the physicians said, we could do that, but our organizations won't let us. They are focused on bottom line, for example, and we are being asked to provide services and care that really are not needed by people. And so this effort is to try to develop a charter for, and the charter has been developed. We're waiting to get it published. And this has been led by the Foundation for Medical Excellence and Barry Edgener, a physician out in California. And it is an interprofessional group that has been developing these standards. I think that it's an opportunity. Teamwork is part of this charter, and equity on these teams is part of this charter. I think the charter represents an opportunity to put forth to healthcare administrators, where is your organization at? Do a whole system evaluation, ask the people in your organization, where is your organization at, and what needs to be the priorities for improving your organization. The other plug, another plug I would like to give is to magnet hospitals. The magnet designation recognizes excellence in nursing care, but it's not just about nursing. It really is about the whole hospital, the whole institution. And it's not perfect, but it has helped us to make strides, for example, in the percentage of nurses with baccalaureate and higher degrees. And it is about helping with culture change. Again, it's not perfect, but it is a mechanism in which to advance a better culture within healthcare organizations. So those are two of the recommendations that I would have specifically with this.
Thank you. Questions from the committee? Oh.
Yeah, since we're on recommendations, one thing that I would recommend from the academic perspective, because we saw this in pharmacy as well, and that is to possibly change the way in which you evaluate candidates for the nursing programs. Because I know in pharmacy, you know, what we call the old days, you know, when we just needed someone to, you know, largely be managing the medication dispensing process, we needed folks who were, you know, just really good in science and math and, you know, had great attention to detail, communication skills weren't, you know, highly valued. But now, since we're moving towards this team-based care environment and pharmacists being more involved in patient care, we have changed our admission requirements in terms of what we look at in interviews to be more holistic and not just looking at the academic record, because we're more interested in a student who comes to us and has the ability to communicate well, has the ability to work as members of a team. So I have created a completely new interview process that engages the students in teamwork in front of us so we can see how well they interact with other members of the team, because we want those softer skills rather than just the hard science skills if they're going to be caring for patients. right? And so that's the one recommendation that I would have. It's a long-term approach, obviously, because, you know, they've got to get through school and then get out into practice. But if we don't change the input that we have, it's going to be much more difficult to change the output.
Yep.
I agree with that, except that I think that schools of nursing are doing that to a large extent. You can graduate this holistic, thoughtful, smart nurse, and when you put them in a healthcare organization that doesn't enable them to practice the full extent of their education and training, doesn't respect what they bring to the table, they lose them. And the research by Christine Kovner and Carol Brewer has shown this in terms of turnover. When that nurse is valued, they stay, they fully participate, but if they're not, they leave.
You need both. You got to have skills first.
So, and I would say both of those observations apply across the health professions. It applies to every health profession, both on the input end and on the synergy between values selected for and taught and values of organization. Yes?
Let me begin by using leadership for the 166th time in this meeting. In many of our leadership models are hierarchical, and Diana's stories about nurses not being allowed to get senior in that hierarchy are absolutely appalling. But when we hear about teamwork, I'm wondering, often we think about teams organized hierarchically, but one of the lessons I drew from the prior panel was that we need to think of our teams as networks, where the leadership keeps moving around the network depending upon the patient needs. And the second thing that I heard, and Diana used the word a few moments ago, is the critical need for if those teams are going to function, for everybody on that team to be valued, and their ability to contribute to the team to be valued, whether they are, let's take hospitals, the doctor, the nurse, the environmental services person, who may be the most knowledgeable and the most critical person in infection control. So what I'm wondering, and I'd like Rebecca and Tom to comment initially on this, but invite other comments. What do you see happening in your organizations or the organizations you've studied to create a greater valuing of all the individuals in the organization and a shift to networked teams and a vision of leadership that is around networking and moving leadership around as appropriate? So that's my question.
Sure, I'll take that on. One of the things I think you see with teams, and I'll go back to the examples that you brought up earlier of the football team versus the basketball team. Those teams have a very clear purpose. Their purpose is to score a goal. The purpose of a care team in healthcare is not always clear, and largely the organization will identify what the purpose is. I would hope and wish that the purpose would be the improved health and wellness of a person seeking care. In many organizations, that's not the case. The purpose may be conserving resources. The purpose may be meeting a certain metric. The purpose may be seeing a certain number of patients per day. In those cases, the teams will form and function for that purpose, and the leadership identified will be appropriate to that purpose. If the team's purpose is to financially sustain the organization, then they will put at the head of that team the person best able to do that, and that's the person best able to earn in the given environment. The practices that I've seen that have actually had a wonderfully fluid and very innovative and successful teaming model are ones that had a purpose of health and wellness, that decided that the needs of the people they serve were the needs of the team, and they designed around that, and then had people that later figured out how to make the business case to support it, or how to get the funding to support it, largely through grants and outside sources and wonderful entrepreneurial spirit of other things they did on the side to support the care that they knew to be right and appropriate and timely for the people that they served.
So I'm going to agree with everything you said except the part where you said the person seeking care, because again, the person seeking care may not be the person who actually needs the care, and there are lots of people out there that probably should be getting care that the team should be responsible for. But I think that point of depends on what your goal is, right? And so you need folks that set the explicit goal of, we're going to improve the health status of a population, and you can define the population in slightly different ways if you'd like. You know, when I was at Geisinger, we took anyone that had seen us once in 3 years as our standard. And our goal was to know their health status, to push care at them if they were failing, or if that wasn't sufficient, to bring them to the part of the system that could most likely match their healthcare needs with the delivery. And so you start with the right goal. I think that's critical. And then you bring everyone to the table. So we shut down all of our primary care offices for 90 minutes every month and blocked out outside influences, if you will, and had everyone that touched a patient in that office sit together and talk about the process of care, the communication between the various team members. And then we did it with data, with quality data, with outcome data, with utilization data. So did we have too many patients going to the emergency room for things that we could have managed? And why was it? And I said, well, it was the weekends or it was the evenings. And no, it was Monday and Tuesday, 9 to 5. And what does that tell us about operations? And you can have the best doctors and the best nurses in the world, but if the front desk person fumbles that first phone call, the team doesn't even get on the field. And so every one of those people was instructed, and we spent a lot of time legitimately asking for their input around those issues, because again, it was things like phone access that were preventing us from achieving our goal of better health. And then we looked at the quality reports, and we looked at it, and sure enough, not only did we get more of the process done, so for those that were counting beans on the primary care side, we billed out $1 million in tetanus shots over 3 years. Well, I don't know that we necessarily stamped out a lot of disease, but you know, with pertussis, maybe we did actually. And we saw patients' control of their blood pressure and cholesterol and blood sugar improve. And then in as little as 3 years, we saw reductions in heart attack and stroke and diabetic nephropathy rates. All right, there's about, 50 people in this room. So we'll count the 30 people that are on the phone. In 1,000 days, if you went to an office site that used this team-based model, one less person had a heart attack out of 80. One less person had a stroke out of 150. Those numbers are huge when you think about the size of the population. We're caring for 25,000 diabetics. That's thousands of heart attacks. We're not talking about decades. We're talking about 3 years. And then in the article has not yet been published, but it'll come out probably in December in American Journal of Managed Care. It turns out over 5 years, that's a lot cheaper to do. So how do we pay for these innovations? We pay for it by the innovations. I mean, the lovely thing about working in innovation in healthcare is it's such a broken system to begin with. Virtually anything you do is likely to result in success. But you have to have all of the people at the room. That process was designed by the people in that room, right? That included doctors and nurses and pharmacists and front desk staff and phone room people and check-in folks and anyone that touched the patient in that chain. And then we had folks from process improvement who could sit there and say, well, this is the broken process. Let's map out the people process, and then we'll build the electronic accelerators to make it go fast and easy so we don't rely on the foibles of the human memory to make sure that we do it every time, every patient. And that, to me, is the important thing. Get the right goal, get the people in the room, redesign the process, and then make it the new way the easiest thing to do, right? We all know that doctors will do the easiest thing for them. So make it the right thing, the easy thing. And if there's something that the health status of the patient dictates be different than that easy way, they're going to do that. But you want the default to be what we know works best for the population. Let them manage the exceptions. They are exquisitely good at that.
Lawrence, one comment, and then we want to move on to some other questions.
Yeah, real quick, on this issue of team leadership, I want to get your thoughts on this. And Thomas, as the physician for the group, you're designated the expert for this question. And I don't know whether this is true or not, but I've talked to multiple physicians over the years related to expanded roles for pharmacists. And one thing that I would hear over and over again related to their reluctance to kind of sharing the process is that they feel that society views them as the ultimate person responsible for their care. And a lot of physicians take that responsibility very seriously. They feel if something happens to that patient, regardless of who touched the patient, they felt ultimately responsible. And I want to get your comments to say, is that actually a general perception or not? And if it is, then is that one of the components that's causing this reluctance to physicians to give up the quarterback role? And is one way to resolve that is to change that dynamic and say, no, you know, all members of that care team are responsible, and they have to step up and admit and agree to being responsible for what happens to that patient. And with that, then, you know, provide a little bit of less risk, as Joseph talked about, to the physician in giving up some of those roles to other practitioners.
Yeah, and I mean, I think the physician as captain of the ship is an apt analogy. I mean, when I was trained, you know, the buck stops with the physician. You are ultimately responsible. And I still think that's probably true. I'm actually a big football fan, and as you can see, I used to play. But you know, and I apologize. I went to the University of Michigan. I was born on the 4th of July, so the New England Patriots are my favorite team. I'm sure that's not necessarily popular around here, but truth be told, you know, even if they have to cheat to win. There's too many instances. Anyway, but you know, there's no question that Tom Brady is in charge of that football. I mean, Bill Belichick might think he is, but Tom Brady is in charge of that football team. No one would question that. But Tom Brady can't tell everyone what to do. He needs each of his teammates doing exactly what they're supposed to do, exactly what they're well-trained to do, making their own best professional judgments about what's happening. You know, you could have an entire team of Tom Brady's, you would lose every single game. If Tom Brady had to tell everybody exactly what to do every step of the play, you would lose every single game. And, you know, with the Wildcat offense, Tom Brady doesn't even get to touch the ball on every play anymore. So I think football is actually an apt term. The physicians, though, have to be comfortable with that leadership role in setting direction and tone and not necessarily micromanaging every element of the care, because there are many things that they are much less well-equipped to do. And I think changing that element of culture where the physicians don't feel that they've lost some of their luster or whatever it is, but are willing to cede that expert role and that element of delivery to others, I think is part of that. Now, maybe my own physician-centric nature is getting in my way, and so I'm willing to admit that possibility.
I think it is a little bit.
Can I jump in?
Joseph, and then we want to get some other
very quickly.
questions in.
I couldn't disagree more. There was a gentleman named Elliot Jacks who is best known for having framed the idea of midlife crisis. But what he's best known for in Europe is the restructuring of the healthcare system in Great Britain, wherein nurses led the organization, nurses led the practice, nurses managed the doctors. And if one looks at the gains in quality, the returns into hospitals, it is an exemplar of well-run healthcare. And they had this thing called an accountable organization in 1953, an accountable organization system where these accountability teams were put together, led by nurses.
Let's move on for some questions. Cynthia, then Richard.
Some of this has been kind of touched on at this point, but I did want to kind of from an appreciative perspective kind of ask, particularly Rebecca, if you could give us some suggestions, because you spoke about something that really does resonate with me, because these practice models happen at the front line every day. I mean, what we are describing is not something that is foreign. I don't discount Diana's examples because they happen every day too, but the positive models that you're describing where there is collaboration also happens every day. And I wonder if you have any suggestions for us as a committee especially as it relates to moving forward, how do we change the conversation from who gets the credit, who's in charge, who's the boss, to here are examples of ways that we are actually managing care in a way that meets the patient's needs, and let's try these. I mean, you know, how do we kind of change the conversation?
So this is the kind of question that somebody like me lives for, and we hope to answer it over the 30 years of our career. So doing it in 30 seconds, it's a little intimidating. Oh, thank you. Oh, thank you, everyone. I think one of the issues is that care doesn't happen in a vacuum. So I take Diane's points to heart, that the employer creates a certain atmosphere in which teams are created. And a lot of times it doesn't matter what the regulations are about scope of work. It matters what the hospital lawyer said a nurse can or can't do. And that's based on a relatively litigious environment that we have, although we often don't discuss it when we talk about teams. It's very much present in the making up of those teams and what people do. What I think these really creative practices did is, first, the leadership said, you all deliver the care, you know the patients and the populations that you serve. We trust you to identify what's right for them. They acknowledge that the right care strategies is usually an organic experience, and it's born of the communities that are being helped, as well as the people who come in the door and the people who provide care. So one of the recommendations would be that the education that we provide for nurses has to be appropriate to that. And that means not only that we have to provide them training and experience that is in community and care delivery settings, not only that we need to provide them with opportunities once they have those degrees to use the skills that they learned in those settings, but it also means that we have to work with the other professions in those settings, the administrative people, the legal people, as well as the management people, to help to explain what the work is that we do and what's important about it and what the priorities are within it. The successful practices are ones that don't assume what their patients expect. They actually talk to the people they serve, and then they answer what that need might be. They have a knowledge not only of the barriers in their communities, but also of the assets in the community, and they work with the community to build on those assets to address the barriers. So they're very experienced with partnering and with leadership that is both very assertive as well as collaborative and sometimes passive, depending on what the situation might be. The training is a key element in that, but creating a receptor site for the people who are trained is also a key element. And I think that part of the culture shift has to happen within primary care in general. We have existed for so long in, and have the book Scarcity recently came out on my mind. We have existed so long in an environment that is so constrained. It is hard for us not to have a tunnel vision about things. And it is hard for us to imagine possibilities outside of fee-for-service. Even bundled payments, somebody said earlier, is partially reorganized around this sort of fee-for-service model. I think that it's indicative of a loss of trust that the public has had in the health professions that we need to gain. There's a PR campaign that then goes with that. And I know that our task is not to create new recommendations, and I think that the four that are there are quite sturdy. But if I could add to them, it would be that there is an aggressive PR campaign that needs to happen within the general public about what they should expect from a healthcare system and what the different roles are within it that can support them. And I would also have an aggressive PR campaign with employers to not do damage to the very systems that the Future of Nursing report has created.
Great answer. So we have Richard, Bob, and Karen, were you holding the microphone? No,
Yeah, but I would reformulated the question.
Okay, so you got time. Richard's next.
Yeah, again, one of the issues has been that we tend to think of the report and all around a nurse-centric So all the discussion here has been about the nurse, the role in the team, bringing in other team members. And, you know, I do a lot on the other side of the world, which is responding to customer and customer-driven as opposed to product-driven or business-driven. And I wonder if you would even think for a second of a model that would be customer-driven, where the customer is the leader of the team. Because when you talk now to people and you see why, you know, telemedicine is picking up, because parents don't want to take one sick kid and one healthy kid to the doctor and miss work and all that sort of stuff, or a team. You know, I just want a Z-Pack. I got an infection. I just want a Z-Pack. I don't want to see a team. I don't have time for a team. Team may be better for me. And it seems like we're not listening to what the customer wants and when they want it, how they want it, where they want it. We're still in this paternalistic idea that we know best, and we're going to fight among us professions how we're going to organize something that may be sort of buggy whippy. So give me a sense of, can you envision a world where the consumer could be the captain of the team?
So I would encourage you to look at these, what we call edge runner models of care. We did an analysis of, we were asked by HRSA, what are the commonalities around nurse design models of care? Does it make a difference that they're nurse designed? And so we did some focus groups around this, and the paper is being published by Nursing Outlook. And what these edge runners, these nurses, consistently said is that we respond to what, we ask the question, what do patients, families, individuals, families, and communities need and want? And we design our services around them. And you're going to hear in the public section, I'm sure, from Ruth Lubick, who will tell you how she does that work around childbirthing centers and meeting the needs of women and families that are starting up. So there are examples out there, and nurses get it about the patient needs to be the center of it. I think the frustration that many nurses feel is that that perspective is not necessarily valued and supported. But look at the edge runners on the Academies website. You'll see a whole host of them. And one of the models that really is on that list is Transforming Care at the Bedside, which Jack knows about. But that is a model that really looked to empower the bedside nurse in medical surgical units, and then became expanded to it's empowering all the people on the front lines, including that person who's cleaning the floor. And some of the initiatives around change that were being led under TCAB were led by the person who cleaned the floor, or the physician, or the nurse, or whomever.
There was a 3.5-hour conversation not too far from here last week, celebrating the 25th anniversary of the Americans with Disabilities Act. Turns out that people with chronic and complex conditions go to the University of Google, and when they go to see their practitioner, whatever, whether it's their primary care practitioner or their specialist, they're much more informed than their practitioner. And they are an example of a group that was disempowered, that became, through state and federal law, the central customer of the support services that they receive so that they might live independently or that they might go to school with appropriate supports. And they are now what I would call a very powerful and incredibly frustrating patient population or customer population when they go in to see primary care providers. And the folks at Kaiser Permanente are taking a look at precisely that population, because they are a great precursor for this group that we call the baby boomers, who also have access to Google and who are very interested in not just the latest pharmaceutical intervention, but perhaps whatever's happening in a journal in New Zealand with their particular skin condition.
Quick comment.
Yeah, and one thing I do want to make sure to bring up is your point's exactly correct. We need to have a customer-focused or patient-centered approach to what we do. But we also need to recognize, as we do, that not all patients are the same. And although we have an increasing number of these engaged Google University-trained patients that are out there, we still have a good portion of the population that are still in the old mindset of just tell me what to do, right? They have low self-efficacy, low locus of control, and they just feel that I should go to the healthcare center and someone should tell me what to do. And in fact, they get confused. if they're engaged and said, oh, what do you think we should do about, and they're like, well, why are you asking me? Aren't you the expert? Shouldn't you know? I mean, why are you asking for my opinion on this? So we need some additional education for those patients to help them understand the rationale for this team-based approach so that they don't get confused and start to lose trust in the healthcare system.
So we're nearing a bewitching hour. We have 4 committee members that would like to ask a question. Ask everybody to keep their question precise and ask one person to respond to it because we have 5 minutes for 4 questions. Bob.
So our charge is to create a brief report looking at the impact of a report 5 years ago and then offering opportunities for acknowledging gaps and looking forward. Scope of practice and education have been heavily hit on, but I want to ask, because you bring it up in several contexts here, if we're going to looking at the future of disruptive nursing, what should we be advising RDBJ, AARP, and the campaigns at the state level around nursing leadership and capacity for diffusing collaborative improvement efforts and for enabling nurses to lead health system change? I've heard some of that here, but I'd love your specific recommendations.
Diana, you want to take that on?
Sure. I think it is about engaging the leaders of healthcare organizations and asking them the question about what is the culture of your organization, and is it a culture that supports whoever the provider is being able to lead, do the work, and be that patient-centered work. I think the culture change is huge. So I would encourage you to address that healthcare organizations and the leaders of those organizations need to step up and rethink what the cultures of their organizations are and how to transform them.
The English major in me loves this conversation. The person with the PhD and how to measure things is getting a lot of indigestion. So if I'm going to measure one really important thing about a team and its function to provide effective care, what's the most important thing to measure with data, not a focus group? I'm going to ask Tom.
That's because I had the puzzled look on my face.
You talk most about data.
Yeah, I like data. If we get back to what the outcome is that we want to do, it's what matters, something that matters to patients, right? So what's the impact on real patient level data, things like heart attacks and strokes? So did the team make a difference or not? And then the issue of who's leading it or how it's being led or what the formulation is becomes a whole lot less important, and the culture of meritocracy reigns. So I'd look at outcomes that matter to patients, and maybe you start by asking patients what matters, and then I think you do have to season in some of that sort of medical knowledge, regardless of what field it comes from, around things, because there's lots of data out there that shows that, when given the choice of how to spend their healthcare dollars, most patients spend it not on the things that will provide them the most health.
For Diana. So we heard a lot yesterday about the limited advances in diversifying the nursing workforce. So can you share a bit about how the Academy plans to address this problem, or do you have any recommendations on how we can better diversify?
Actually, we have a diversity and inclusivity committee that was a task force, and the board is so committed to the issue that we turned it into a standing committee. And we've told that committee, we want your advice on how to be a model organization of diversity and inclusivity. And it's not just the diversity, it's having how do we make sure that when people are at the table, they don't feel marginalized, that they feel that they can bring different perspectives, and those perspectives are valued and heard. Similarly, I know I do wear a hat as a strategic advisor for the Campaign for Action, and I know that the diversity work is a huge commitment there. In my own state of New York, we have a diversity toolkit that we're rolling out, so I think you see a lot of commitment to helping to move forward this issue of diversity in nursing and having the nursing workforce reflect our patient population and not just look like the patient population, but have full voice at the table.
With new technology, how much should we take into consideration things like mobile apps, WebMD, Google, and other platforms that patients are going to get information? Would you see that as a component of team-based care, or would that be a stretch?
So today, mobile technology and other elements, I mean, they're a reality of how healthcare is delivered. And so understanding, to me, that's where you have to know what's the best, what's a patient's need, medical need, and how can we best meet it? And if we can do it in a way that is in their hand at their work site, that's great. And if we can't meet it there, then what's the closest to home, most convenient methodology that will likely result in success, right? We're not going to solve a heart attack over a mobile phone. On the other hand, there's lots of care that's currently delivered in hospitals that probably shouldn't be. And so it's a process tool, but I think the culture has to drive it first, and the focused on outcomes element will be what is the modulator of that flow.
I would just add to that what we heard in the panel earlier. Mobile apps and that virtual extension is fantastic, but the connectedness that we need is a level that goes below that surface. It's not enough to like, tag, friend, or follow. You need to have a relationship established in order for those things to be an extension of that relationship. The technology is fetishized a little bit. And if we invest too much in the technology and don't think first about what it is extending or what it's serving, then we create really cool tools that serve to distance lots and lots of people.
And I would refer you to the work of edge runner Christy Henderson in Mississippi, who has developed in telehealth, used telehealth to really reach rural areas and make sure that nurse practitioners in those rural areas have access to emergency physicians and others within the University of Mississippi Medical Center, and she's ramping that up.
So we've reached the end of our time. I want to thank the panelists for an absolutely stimulating panel. It's very clear you've given us a lot of food for thought. We could have kept going, and I think you've highlighted once again the importance of this culture change to achieve the goals of the Future of Nursing report. We're now going to go into a public session that Stuart will moderate, and thank you all very much.